Hello friends, today we'll be discussing about the antibiotic resistance. Before going into the antibiotic resistance, you have to understand there are a lot of issues going on, that why there is a judicial use of antibiotic is necessary, why there is always point comes that there is a need of antibiotic stewardship. Judicial use, everywhere you are saying this. Now we are going to enter into the post-antibiotic era. When Alexander Fleming in 1928, he found that when he came back from a holiday of 7 to 10 days, I think, went to the holiday and come back to the St. Mary Hospital. Then he found that his colony of Staphylococcus aureus, the glet, was contaminated with the Penicillium notatum. When he found that his plate has been contaminated from this mold, the area nearby this mold, the colonies of Staph aureus were found to be hemolyzed. Then he concluded that okay, there is something in this Penicillium notatum that has been caused the lysis of this bacteria, this Staph aureus, and he named it as a penicillin. It was 1928. He knows that there is something. He named it as a penicillin in that culture plate in the mold. He found that there is something that can kill the bacteria, and he named it penicillin. But it was not enough, because he was not able to extract that penicillin from that mold. Then 2 to 3 years later, there was a team from Oxford, that is Howard Florey and his team, found out that they were able to borrow that from Alexander Fleming and able to extract that compound from Penicillium notatum. But still nobody knows that it will work or not. Everybody was scared that it will be a good go for the human trial or not. There were a dilemma to use it or not. They have extracted a small amount, they have it with them, but they were not able to use them. Accidentally, one of the Oxford University gardener named Alexander, it was not Alexander Fleming, but name was Alexander of that gardener. He got scratched with the thorny while working in the garden. Later on, he developed sepsis. He went to the ICUs. Then they thought to use this penicillin extracted compound into him, although he was going to die. So there was no question was of ethical issues, and they agreed. The ethical committee agreed. So let's try for it, and they have given that aliquot to this Alexander. His sepsis was improved. But since he had a small amount of aliquot, they had to collect the urine of that patient, run out the street, and again purify that compound and again give him. This process was continuous because the amount of penicillin was very small with them. They were unable to survive. But they were able to know that this is going to work. The extracted compound is going to work, and later on they have made a mass production, and it was a very useful drug, very useful thing in the Second World War, and lots of millions of the soldiers were saved through that penicillin only. And after the development of penicillin, there are a lot of antibiotics have been developed through the pipeline till now. And since the antibiotic get developed, the resistant in 1 to 2 years become predominant, comes into the market that it has been resistant to this drug. This organism has found to be resistant. So whatever will make the antibiotics, the bacteria are going to win this battle. They are in 1 month or 1 year or 2 years, they are going to develop resistance to this, and they have several mechanisms of going to develop the resistance. Like they are having these enzymes that modified this drug. They are having the modification of the target site for which we have targeted and made the drug to kill that bacteria. They have modification of this metabolic enzymes are there, they are modified the metabolic pathway, they have the flux pump, they have the different resistance mechanism by which they get overcome to our weapon, our antibiotics. So before understanding that, you need to understand other thing as well. There is always a point of saying that okay, we used to need the narrow spectrum antibiotic, and there should be a judicial use of antibiotic. There should be antibiotic stewardship. Why this thing has come forward? Why you are saying why this has come forward? To understand that, you have to understand one major thing, and that is the selection pressure. Our whole body has been full of normal flora. The normal flora, the normal bacteria that is present at that particular anatomical site is useful for us, is actually protecting us. There are certain flora in our skin like Staph epidermidis, Staph aureus and other as well. But they are on the skin only. If they goes to the blood, then they will going to cause us infection. They are going to cause us the bacterium and septicemia. There are lots, tons and tons of bacteria in the intestine. But if they are in the intestine, there is no problem. But if they comes to the urine, then you get the urine tract infection. So to understand this thing, we have to know the understand about selection pressure, and that is very important. So we are talking about selection pressure. Selection pressure normally has, these are the antibiotics that have been present in our body. Okay. Now when we going to use any antibiotic, suppose these are the normal flora, that is the sensitive and resistant bacteria is there. So you have to one thing you have to understand very clearly, that your normal flora, your body has the bacteria that has both the sensitive and the resistant bacteria present inside your body only. There are this, you can see that green bacteria, that is the sensitive one, and the red bacteria, that is the resistant one. So your body has mixture of bacteria, mixture of normal flora. When you are going to use any antibiotic over there, then what happens? This antibiotic will going to kill all this sensitive bacteria present inside your body. So what happened? Now you have this group of bacteria. You have used the antibiotic. Now this antibiotic has leads to the wipe out of all the normal flora, all the normal bacteria that were sensitive. And since they were sensitive, they were being killed by the antibiotic that has been used by you or by your doctor. So what happened? Anybody has used the antibiotic is normal flora. Actually, this has been used to kill the pathogenic organism. So suppose we have a viral abscess here, we have a pneumonia. Some antibiotic has been prescribed to you. It is going to kill the pathogenic organism, but it is going to kill your normal flora as well. Okay? Since your normal flora has been killed, now what happened? Now this selected resistant bacteria that is present inside your body has been selected out. This has been cleared out. Now the left bacteria that is inside your body is only this resistant one. You have to understand one thing more, that the antibiotics that have been used was for the purpose to cure one infection. But on the other hand, it is going to cure your infection from that side of the body. But on the other hand, the normal flora that were present in your body at different anatomical site, the sensitive one are wiped out, are clear one. But the resistant one will not clear because they are resistant to this antibiotics. Whatever antibiotic you use colistin, you use one of the broadest antibiotic present in this world, but you cannot wipe out all the bacteria that is present in your body, because we have the bacteria in our body that are resistant to the widest antibiotic available till now. Okay, for understanding this, you have to look. One antibiotic has been made for target of one kind of bacteria, one kind of organism. So if you are using, say, highest antibiotic, you are using colistin. So colistin will kill all the gram negative. It will not going to kill gram positive. It is going to kill gram negative. But in gram negative also there are certain bugs that are intrinsically resistant to this colistin. And also there are the now issues as come in that a sensitive bacteria has also been acquired resistance to this colistin. So all those organisms that has been intrinsically resistant like Probentensia, Proteus, Morganella, this group of organisms, Burkholderia, some of the Stenotrophomonas. These all are the that are not going to kill out. They will remain inside your body. And since they are not going to kill, they will multiply, and they will be the only organism now left in your body. So you are now become a bioterrorist. You have all the organisms in your body that are very much resistant. Now, when you are going to have infection second time, suppose we have used the widest antibiotic, we have cured you, we have sent you home. But while sending you home, what we are giving you, what we are sending you, you came with a sensitive bacteria inside your body. We have wiped it out. Now you have only the resistant bacteria, and this will multiply and cover whole your body. Now you are only full of this resistant bacteria inside your body. What happens? When you are going to have second infection, then your infection will be only through this bacteria, resistant one. And now, since we have no antibiotic left to kill this organism, you die. We are unable to save it because we don't have the antibiotic available to kill this bacteria, at least not in India. Okay, so you have to understand this point. Now another side of the story is that you are full of the resistant bacteria. You are going home, you are going to in the community. Now wherever you go, suppose you go into the family, when you are hugging, handshake, using the bathroom, using the common room, using the dining table, you are sharing your normal flora with them. Your normal flora is now resistant one. So your resistant bacteria will either transport that bacteria to their relatives, your children, your wife, your daughter, your grandfather, your fathers. How do your bacteria get horizontal transfer of this plasmid, the gene, the drug resistant gene, to their normal flora? So the bacteria will be same to them, but you have transferred the resistant gene to them. Now what happened? Their bacteria are also getting resistant to them, resistant to this antibiotic which we have used. Now what happened? Now if they are going to get sick, they are going to get infected, then we have to use the empirical antibiotic. When they come first time also, the lower antibiotic is not going to work. Now we have to use higher antibiotic in them as well. And higher antibiotic use has again the same cycle will go run in him or her also. You will able to save this time, but you will send him or back home with the same high resistant bacteria inside the body. So this is very important. This cycle, this concept is very much important. Okay. So to understand that, you always at least be sure that if there is any infection and that can be killed, that can be cured by narrow spectrum antibiotic, then always prefer that. If some doctor, if somebody is going to cure you, suppose if you are in ICU, then the only point is to save you. And at that time there is no question, there is no anything that we'll use the narrow spectrum, we'll maintain this antibiotic stewardship. That doesn't work in the ICUs, because we have to save the life, and saving life is most important thing. But when you are not at the risk of your life, when there is no threat to life, you have a simple infection. In that case, if somebody is going to give you a broad spectrum antibiotic, his intention is clear to cure you, but on the contrary, on the consequences, the collateral damage is he or she is making you a resistant organism in your body, and that is actually harming you. The intention may be alright, he or she, according to the knowledge, is trying to cure you, but the collateral damage is harming you more. because whenever you are getting second time infection, or you are going to your relatives and transferring your gene, then this is going to be very bad. This is going to be a worse situation. Now your second time infection will not be cured by the antibiotic which has been used previously. Okay, so the thing you have to understand that why there is, in the hospital, when you are a doctor, you are going to see one patient, you don't know what kind of bacteria he have. When you examine, when you touch, when you examine the patient, when you treat, when you come in contact with the patient, you are sharing his flora with you. If he has a resistant one and you are without hand washing, if you are going to see the second patient, then you are transferring that resistant bacteria, that normal flora, to the other patient. The other patient may be a normal one, just a sensitive bacteria present in his or her body, or came presented with a normal infection, sensitive one, that can be cured by the simple antibiotic. But while you are transferring the resistant bacteria, now you are going to make him also the resistant, his normal flora also the resistant. And now if he is going to get admitted in the hospital, when he get too sick, his normal flora, suppose he get intubated due to any reason, he gone to the surgery, have intubated. Now there will be micro aspiration. If his flora has already been resistant, he will have infection with the resistant bug. Now you cannot manage him with a simple antibiotic. In Medanta, when any patient come, we used to check carba-R test. That is, we used to take the rectal swab and use a carba-R test. That if a carba-R test is positive, it indicates that his body, his intestine is full of the, not full of, but his intestine has the bacteria that is resistant to this carbapenem. And since he are already resistant to this carbapenem, we assume that his infection, suppose he or she is in sepsis, shock, and any other severe infection is presented. Now we have to assume that, okay, he already have carbapenem resistant organism in his body. So whenever we are going to give empirical antibiotic, we will give higher antibiotic to cover the infection. Empirically, now we have no options. We cannot start with the lower antibiotic, because in sepsis, if you are not going to give the proper antibiotic, then he or she will die. So you have to understand this mechanism. This seems to be very simple, but if you understand this process, then you will always be think not once, you will think 100 times before giving any antibiotic to any person, mainly the wide spectrum, broad spectrum. Because for that you should have a sound knowledge. Actually, to prescribe a judicial use of antibiotic, you have to have a sound knowledge about antibiotic. Not only the sound knowledge about antibiotic, about the bugs, the bacteria as well. You should know what antibiotic will be worked for it. Suppose any staph infection, if it is the sensitive one, the napcillin, oxacillin, cloxacillin, flucloxacillin, they are very sensitive to it. Then it is going to be cured with that antibiotic. You don't need to use vancomycin or teicoplanin or other drug as well. So you have to understand that point. If you are not going to understand that point, suppose since you have used only flucloxacillin, this flucloxacillin has very narrow spectrum. They are not going to kill 2 or 3 bacteria, or the only sensitive one. So this is not affecting your normal flora in your body. Likewise, there are many other narrow spectrum antibiotics that has to be used judicially. Whenever the infection is small, whenever the infection is not threatened to life, you should always try with narrow spectrum antibiotic. Actually, this is good for the patient only, and for all this global threat of antibiotic resistance. I hope I made some point and be able to understand you. Thank you so much.